Hello everybody, and we're going to do our next obstructive case. Our patient is a 52-year-old woman who was referred to a pulmonologist for worsening cough and sputum production for over nearly 2 years. She also complained of shortness of breath and fatigue. This patient is a non-smoker. She's thin but not cachexic. She doesn't have any significant medical problems, except that she has been treated 6 times for bronchitis over the past year and a half. She doesn't have any systemic inflammatory disease or history of other major chest infections or tuberculosis, and she doesn't have any family history of lung disease. They did a chest x-ray and a CT scan on this patient's chest and airways. And the chest x-ray, as you can see here on the screen, was positive for what's called the tram track sign. And the blue arrows are pointing to the tram track. Basically, you can see the outline of the airway as if it's 2 parallel lines that look like a train track. So this is unusual that you can see that clarity in the walls of the airways. So it's a sign on the chest x-ray of a dilated airway. On the high resolution CT scan, she had what's called a signet ring sign. Basically, it is a sign that looks like a kind of engagement ring, where the size of the bronchi and the airway should be about the same size. If they're out of proportion of each other, if the bronchus is enlarged compared to the small artery that's running next to it, this is another sign of a dilated airway, because in theory, these should be the same size. So the blue arrow on this picture is showing you this ring sign where you can kind of see what looks like a diamond ring. The size of the airway is much larger than the size of the vessel. So they have 2 signs on imaging of dilated airways in this patient's lungs. All of her blood tests are normal. And when they do a pulmonary function test, they find reduced lung vital capacity. Her FEV1 to FVC is 0.62, but they repeat the test after an inhaled bronchodilator, and it does improve the value. They culture some of her produced sputum and find it positive for a bacteria. So she's harboring a bacteria in her lungs, and she has dilated airways. From these findings, the patient is diagnosed with bronchiectasis. Now, bronchiectasis is a lung disease that we did not talk about in pathophys. So we're going to go through kind of what this disease is here so that we're all on the same page. Bronchiectasis is permanent dilation of bronchi and bronchioles, secondary to destruction of the smooth muscle and supporting elastic tissue. Now, it's normal with viral and bacterial pneumonias that you can get dilation of the airways. And when it's in response to some kind of an infection, this is a reversible dilation. But what makes bronchiectasis kind of a standalone disease is we are talking about irreversible, permanent dilation. And this usually occurs somewhere between the 4th and the 9th generation of the bronchi, because the larger bronchi are protected by cartilage. So they are typically saved from this dilation, and it's only when you get deeper into the lung that the destruction causes this permanent dilation. So the fact that it's irreversible makes this a permanent and permanent disease. And it is related to the destruction of the smooth muscle and the elastic tissue. Many times, bronchiectasis is associated with a necrotizing infection, so it's killing off these cells, causing this permanent damage. The bronchiectasis itself can be localized or diffuse, but it's usually found in bilateral lower lobes, but it can be a very isolated bronchiectasis. In order to make the diagnosis, it's very much what we saw with our patient. They gather data from imaging like chest x-rays and chest CT scans. They do pulmonary function tests to see flow rates. They culture the sputum and they do arterial blood gases to determine the presence of bronchiectasis. So the cause can be variable. If something obstructs an airway, tumor, foreign body, a mucus impaction, you can get that obstruction can lead to a stretching and a death of some of the tissues around that area and lead to the permanent dilation. Severe asthma and chronic bronchitis can cause a more diffuse obstruction. We see bronchiectasis following a bronchial wall injury, and it can be seen with fibrosis when the tissue becomes so scarred that the scarring actually pulls the airway open. It's a little bit of a different mechanism than a typical bronchiectasis, but it presents with symptoms that are the same. So let's talk through the pathogenesis. On the top of your next page of your notes, there's space in your notes to draw along with me, and I'm going to go to the whiteboard. So I'm going to draw a series of 4 different individual alveoli to demonstrate the pathogenesis of this disease. So if we start with a relatively normal looking alveoli here, and we give this alveoli an obstruction of some kind, something blocks the airway, whether it is a tumor, foreign body, mucus, whatever is the obstruction, you've blocked air leaving this section of the lung or from this alveoli. And what ultimately will happen following an obstruction is you will get atelectasis. The air will eventually get resorbed and the alveoli will collapse. So if we move to the next stage of this disease, I'm going to redraw this same airway with the same obstruction, but now instead of a nice round alveoli at the end, we see this collapsed alveoli. So without being able to have air flow out of this area, this is going to impair clearance. And our body is constantly making mucus. And if we can't have airflow moving that mucus up and out, it will accumulate, especially in the lower lobes of the lung where gravity pulls that fluid down. So when you can no longer breathe out to move the fluid up, impaired clearance will lead to mucus and secretions accumulating. Mucus and secretions accumulate. So we'll draw that in here. So we start to get mucus and secretions accumulating in this airway. Now, bacteria loves warm, wet, dark environments. So deep in the lung, where we start accumulating mucus and secretions, this is an ideal place for bacterial growth. A warm, wet, dark environment, bacteria would love to grow here, and they do. So if we move on to the next stage, and I'll redraw this same airway, still having the obstruction with the closed atelectic alveoli at the bottom, and the airway accumulated with mucus and secretions. The body is going to react to this bacteria and this growth with inflammation. So we see bronchial wall inflammation. So I'll draw this as like excitement, even though inflammation's probably not that exciting. What comes with bronchial wall inflammation? Inflammatory cells. And you guys know, hopefully by now, once the inflammatory cells show up, there's going to be some amount of destruction. So the inflammatory cells arrive on the scene to try to help kill the bacteria, but they ultimately also damage the bronchial wall and kill off the ciliated cells. So the presence of in the inflammatory cells damage the bronchial wall and ciliated cells. So now we have destruction of some of the elastic properties of the wall, and we're losing cilia, so we're going to be even worse at beating this mucus and bacterial growth out. And as the walls lose their integrity, they're going to lose their shape. So as a result of this inflammatory response, we ultimately are going to see the walls of the bronchiole get dilated. So here is our same obstruction. Here's our same atelectic endpoint. We're still filled with mucus and secretions, but you can see the airways have completely lost their structure and they've become extremely dilated. And this is a permanent change. We see dilated bronchioles. So, if you look at the kind of number 2 stage here, the mucus accumulating here was cause for bacterial growth. That led to the inflammation, which led to the damage to the walls. But we haven't actually removed the mucus, the secretions. They're still there. So what happens is this bronchiole gets involved in a repeated cycle of infections, and they get chronic infections. Bacteria grows, more inflammatory cells come, the walls get further destroyed, but the mucus can't get out because there's no airway behind it, so bacteria continues to grow, and around you go. So when our patient showed up and her bronchioles were much larger than the blood vessels behind it, and she had positive tram track signs on her chest x-ray, it was evidence that she's gone through the cycle many times, and she is sitting with very dilated bronchioles that are filled with mucus and secretions that she cannot effectively clear out. So if we go back to our case, the symptoms very much match this pathophysiology. Patients with bronchiectasis have a chronic and productive cough. Productive is really, really key here. These patients have a ton of mucus and secretions that are in their lungs and they can't get rid of. They typically present with a fever because of the harboring of bacterial infections. And they have expectoration of copious amounts of foul-smelling, purulent sputum. The term purulent means their sputum contains pus. Pus is the whitish yellow collection of the dead white blood cells and bacteria. So that's again why that secretion changes color. This of course provides the symptom of dyspnea because of the mechanical changes in the lung that come from the disease process, give that feedback loop up to the brainstem to drive breathing and give the sensation of difficult and labored breathing. And there is the chance of coughing up blood, hemoptysis, especially in the older patients. So the patient diagnosed with bronchiectasis would begin treatment. The treatment for bronchiectasis typically includes bronchodilators to help clear from the, open the airways that are blocked with mucus to allow some clearance, antibiotics to kill the harbored infection, and then a referral to physical therapy. So for this patient, goals that would be appropriate would be secretion management, teaching her to deal with dyspnea and shortness of breath using pursed-lip breathing, paced breathing with activity, teaching her positions that relieve dyspnea, energy conservation approaches to ADLs and other functional goals, and then education on self-management of the disease. So at this point, we've talked about a number of these, but today I'm going to really focus on the secretion management, because this is something that we can do as physical therapists. It's also part of the job of a respiratory therapist. So depending on the area of the country that you work in and your particular institution, you may have a larger or a smaller role in secretion management if this is the type of patient you are treating. But it's certainly within our care to deal with secretion management, and sometimes it's necessary to do secretion management first to make them more successful in your functional goals second. So airway clearance techniques are manual or mechanical procedures that facilitate mobilization of secretions from the airways. If you can help facilitate the movement of secretions out of the lungs, you can optimize airway patency and increase VQ matching. So in our patient who had this blocked airway, right, there's no fresh oxygen making it to this alveoli, and yet there is blood flow going by. So this results in a VQ mismatch where we are shunting blood from one side of the lung to the other without picking up oxygen. This is going to contribute to the dyspnea, because if we can't get enough oxygen into our arterial blood, that would be picked up by our chemoreceptors and reported back as an air hunger. So if we can clear out the secretion, you can improve the matching of where the air and the blood is going to get better oxygenation into the blood. By clearing the airways, you'll allow alveolar expansion and ventilation, and this should improve gas exchange. So you can hopefully see that this would be very beneficial to do, perhaps right before you do an exercise, or to teach them techniques so they're good at doing their clearance, they can be more successful doing their exercise. So our airway clearance techniques we will do and talk about in lab as well. We're just going to touch on some of the information here. Let's first talk about postural drainage. Postural drainage is going to be a topic of one of our weekly discussion sections, part of lab, because we're not going to put patients onto a tilt table and do postural drainage, but I think it's important to think through the physiology of it. Both for those of you who just want to be able to answer the question right on your boards, and those of you that want to use this, it's a really good way to be able to solve this problem, whether on an exam or a person in front of you, if you understand the physiology more than just memorizing a set of positions. The goal basically is to take the section of the lung that has secretions and tip it so that gravity helps to just naturally kind of pour the secretions out. So you think about the anatomy of the lung and you put that into a dependent position to let gravity help pull the secretions out, is the primary thought behind postural drainage. Like I said, we'll go into greater depth of this in our discussion section. You can combine postural drainage with techniques that would help move the fluid. So percussion is the first one. Percussion is something you guys hopefully did in your summer when you did your massage techniques. That's when you mechanically apply kind of a rhythmic beating to the chest wall. You can use your hands. As you can see, there's many devices that you can use to create the vibration. But basically, the vibration kind of shakes the secretions loose, kind of frees them so they're more easy to move. So if you're having the patient in a position where the secretions are draining out of the lung, and then you add a percussion on top of that, you can get a better mobilization of the secretions and help to remove them from the lungs. Vibration is a very similar idea. It aids the movement of secretions into the central airways during exhalation. So when they're exhaling, you can take and vibrate the lungs. I want to show you a short video. This is a couple. The girl in the video has cystic fibrosis, which is a diagnosis we'll talk about in a lecture or two from now. But they kind of walk through, this is kind of their own personal YouTube channel, and they're instructing other people on how to do these techniques like percussion and vibration. And I really like this video because in the real world, it is family members that are frequently doing this care. So we'll provide the instruction. But I think they do a really nice job of showing these techniques and explaining it in a very kind of layperson term. So I'm going to let them show you how they do their home secretion management, just the two of them.
You can do these in different orders. This is the order that we've done, and it works best for us.
So we're gonna start on her upper right side, cup the hands, and 3 to 5 minutes.
And you can put a pillow in between your legs if that's more comfortable for you. And yeah, it's just a matter of like figuring out how it's most tolerable.
Yep. All right, once you're done the 3 to 5 minutes, do your vibes. And as you're learning to do this cupping technique, it might be helpful to notice the difference on your own hands. If you clap them together, it kind of makes that smack, and then practice cupping and it makes more of a hollow sound.
That's pretty good. I tend to try to kind of control my cough during the vibrations. My body wants to cough right away, but I've noticed that if I try to hold my cough in for the vibrations at the very end, then all the mucus is loosened and ready to come out. If I cough on all the vibrations, I do get mucus up, but it's more effective if I kind of focus on controlling it and letting the vibrations do their work, and then at the end I let my body cough really hard and it gets mucus out. So it's something to try.
So I really like that video series. We talk a bit in lab about how you can hear the kind of the rattling of the secretions, and I hope you were able to appreciate that in the video. I think you can also see from the top, if you want to watch more of it, you can feel free to just check it out on YouTube. They do a bunch of different videos if you're interested in that patient population. They're a really sweet couple. So postural drainage works very well. It has some big negatives though. And one of the big negatives is that it's uncomfortable. It's uncomfortable to be laying and you're with your head down in that position for a long period of time. Many patients end up getting GERD, gastroesophageal reflux disease, because they're tipping upside down and adding the vibration, and that ends up allowing stomach contents to leak into their esophagus, which can cause a chronic irritation to the esophagus. During postural drainage, it's possible they can desat. They get really short of breath. They can get headaches and sinus pain. And a really big one is that it depends on a caregiver to do that additional percussion and vibration. And that is hard if someone doesn't have a person who's dedicated to that role. It's also hard on a person who is the caregiver, because they can end up with repetitive strain injuries. So when you're teaching a patient team about this, you really want to make sure that the caregiver is thinking about their own body mechanics, just the way that you guys do as therapists, how important it is to take care of your body first so you can give care over the long term of your career. The other real big negative is to effectively do postural drainage, you need a tilt table. As you can see in the picture, many positions have the feet higher than the head to allow for the drainage positions, and not many people have a tilt table, or it would be really expensive. So they have come up with a modified postural drainage position. Basically, they don't have a tilt table, but they use pillows to try to create a position that helps with drainage. Gravity still has the same effect on the mucus, and typically patients can tolerate these positions a little bit more than they can with the full postural drainage. You can add percussion, vibration, deep breathing to any of these as well. So this was a really big study that came out. It was a Cochrane database of systematic reviews that was comparing other forms of airway clearance to postural drainage, because for many, many years, postural drainage was the gold standard, and people did not believe there was a better way to get these secretions out. So even though it has a pretty long list of negatives, if you had a diagnosis with copious amounts of secretion production, postural drainage was basically the golden bullet. That's what all you had to work with. But there's been a number of other airway clearance techniques that have been proposed and have been studied and now are being used in the clinic. And this study compared some of the newer airway clearance techniques and found that conventional postural drainage demonstrates no advantage over other airway clearance techniques. So if you can learn these other techniques well and teach them well and have your patients do them, they can become independent in clearing their secretions without the need for postural drainage. Now, those of you who are going to go into this field, you are going to find many older clinicians that would push back on this concept, that they think postural drainage is the way to go. You will meet many patients who just prefer it. It's the way they've dealt with their secretions over their lifetime. If somebody has a way that's working for them, there's no need to change it or intervene. Postural drainage does work really well. But if you're treating someone for the first time, this is a new concept to them, they may prefer some of the more modern airway clearance techniques as they are more independent and are a little more comfortable than postural drainage. So the next three on the list, coughing and huffing, active cycle breathing, and autogenic drainage, all rely on airflow and ventilation to move mucus. So the first thing to really think about, and here's kind of a cross section of an airway, the yellow being the mucus that is lining this airway. The only way any of these techniques work is if there is airflow beyond the mucus, distal to the mucus. Or I should say there has to be air distal to the mucus to allow airflow to go by the mucus. So we need to have air moving over the surface of the mucus in order for these techniques to work. And the reason you need air moving is that air creates a shear force on the liquid layer. And that shear force helps to move the secretions toward the central bronchioles. The higher the airflow rates, the better the mucus will move. So that seems very intuitive. The harder the air goes by the mucus, the more it's going to drag with it. That'll become really important when we talk about these techniques. How do you create the highest airflow rates to get the best benefit of moving the mucus? Let's first talk about coughing and huffing. So the huffing is a way to produce high flow rates, and it limits the amount of airway collapse. In a traditional cough, you close your glottis to build the pressure, but some individuals will suffer from premature airway collapse, which means that by closing the glottis, they have these high pressures that trap the air in the lungs. So when they go to cough, if airways have collapsed, there's no air moving by the secretions. So coughing alone for someone who has chronic secretion accumulation can be really ineffective. And that's why the gal in the video mentioned that she tries to hold her cough back as long as she can. And we'll keep coming back to this, that coughing really clears secretions from your upper airways, But if you try to cough when secretions are still deep in your lung, you can actually just pinch off airways and trap that down in your lungs and not get any airflow by the mucus at all. So huffing is a way that you can get high airflow without that premature collapse. And huffing is exactly what kind of it sounds like. It's the breath that you use when you want to fog up a glass or a mirror. It's a large, you get big inhalation and then you do a forced exhalation, but you never close your glottis. So big, round, open mouth. When you're teaching huffing, if you hear a high-pitched wheeze, that might be that they're pushing out too forcefully, and the muscles around the lung, that pressure that it's putting on the lung is actually collapsing airways and creating narrowing. So you shouldn't hear any wheezing on a huff. They might have to push less forcefully, because if they're pushing so forcefully, they're closing airways. They're not accomplishing their goal to begin with. So I'm hoping that you were able to hear in the video the girl's sound of her secretions. You could actually hear kind of the rattling. So if you're using huff to clear secretion, they should continue to huff until it sounds dry. So when you're comparing a huff to a cough, huffing works better at moving sputum from these kind of smaller airways into the larger airways. Whereas a cough is good at removing sputum from your upper airways. But coughing alone will not remove secretions from these small airways. They will get trapped if you cough. So if you need to get secretions out of the lung, you have to find a way to get it out of this lower area of the lung first and have it delivered into the upper airways for the cough to be effective. So I'm going to move into talking about a cough now, but I really want to drive home the idea that coughing alone does not remove sputum from small airways. And it is a common strategy because that is our reflex, that when we have irritation in the airways, it triggers a cough. And it can really work against these patients. They can have ineffective coughing where they have violent coughing attacks without any clearance. And it's a waste of energy. It can actually cause musculoskeletal injury, and it's not giving them anything. So we have to try to educate patients on the anatomy of their lungs and how they can clear their lower lungs first. So huffing is one way to effectively move sputum from small airways to larger airways. Once they've effectively collected secretions in their upper airways, then you want to make sure you have a really good cough. So we've talked about this a little bit already, and we're going to go through it in lab. I'm not sure exactly when this video will fall for you personally, if you've already had the lab with this, but hopefully it should support it, whether it's coming before or after. The positioning for the cough is extremely important, in that you want to allow movement of the trunk that's possible. Because for a good cough, you need a really good inhalation. So you're going to need trunk extension to support a good inhalation. And then you're going to need a forceful exhalation. So you're going to want to allow trunk flexion. The inspiratory phase is really important because the more air you get in, the higher the flow rates you can get out. You need a big bolus of air to be moving along these mucus-lined airways to create a good shear force. So inspiration can be supported by a number of the things we've talked about in lab. Really good diaphragmatic breathing might give you a nice big inhalation. Utilizing stacked breathing, where you selectively increase your inhalation to get it more in on the inspiration side before you exhale. Combining inspiration with actions, trunk extension, shoulder flexion and abduction, external rotation, gaze upward, anything to cue in and support a larger inspiration can effectively help their cough. Being able to hold the cough is really important. Being able to hold your pressure before you allow the exhalation phase of your cough is really important, because by having a good glottis closure that allows that positive pressure to build in the thoracic cage to allow really high flow rates. So the timing of being able to hold that glottis closed and the reason that you hold it is important to educate your patients on. For exhalation, you want to allow the best chance to get a forceful exhalation. So you want to maximize intrathoracic and intra-abdominal pressures with muscle contraction and trunk flexion. So exhalation is looking down, trunk flexion, shoulder extension, getting your arms involved, bending forward to get as much as you possibly can out. We'll teach about how patients can actually help assist their exhalation if they have weakness in these muscles, that they can do a assisted cough with their own arms to help facilitate a stronger intrathoracic and intra-abdominal positive pressure. And then making sure the timing of these movements and this breath is all coordinated is necessary for a really good cough. So for some individuals, they might need help to get a good cough. When we talk about splinting is when you try to stabilize a incision point. So after a surgery, the incision site can be extremely painful. And a cough is a really violent motion that tugs on the muscles in the skin and the stitches, and the pain could limit their coughing. And you do not want to limit the coughing because they're going to put them at risk for pneumonia. So by holding a pillow against the incision, you can stabilize the two sides of the wound. It can make coughing much more comfortable. And then you can manually assist the cough, which we will do in lab, where you can be the one that creates that external pressure to aid in the positive pressure buildup of the exhalation phase. The next technique is called active cycle breathing, and we will go through this technique in our discussion section. So I'll just kind of lay out the groundwork here. It's using breath and breath holds to facilitate the movement of secretions. So you put the patient in a bronchial drainage position, so gravity is helping you. And breath control refers to this quiet diaphragmatic breathing. In the chart, you can see it right here, is BC stands for breath control. Breath control is a way to calm down any anxiety associated with these breathing techniques, because when secretions move, it can cause some anxiety in patients. It allows for good oxygen saturation. If at any point during any breathing technique, patients become lightheaded or desat, you just stop the technique and go to breath control to allow for them to calm down. It relaxes their upper chest. Breath control can reduce bronchospasm, and it can help reduce any oxygen desaturation that occurred during the maneuver. So educating patients on how they always have this safe place to go back to restore their breath and restore their oxygen levels. Active cycle of breathing uses a really large inspiration and then a breath hold. The breath hold is really important because when we introduced this concept of using breathing to move secretions, the one big rule was you have to have breath, you have to have air distal to the secretions in order to move them. Okay, the air has to be distal to the secretions in order to move it, because you have to get flow to go past the mucus. Obviously, air has to be beyond the mucus. So with the breath hold, it gives some time for that air to be in the alveoli. And there are connections between alveoli and between the smallest bronchioles. You can see here the pores of Kahn are actual kind of pores or little channels between alveoli. The canal of Lambert is another way that bronchioles can have a gas exchange with other alveoli. So this alveoli colored in on the screen has an obstruction, so it might not be getting good air in. So if you breathe air into this alveoli and you get a lot of oxygen in here and you have a breath hold, you allow time for that oxygen to move over to this attached alveoli so that air can get behind this mucus plug for the exhalation. So the breath hold time allows gases to move between alveoli deep in the lung. And you can allow some increased volume to get behind the mucus, so that when you go to the exhalation phase, there's air to move past that mucus. So you do these big inhalations with a breath hold at the top, followed by the exhalation phase. You do this several times, and you ultimately clear it with a huff to get any secretions that you accumulated. Autogenic drainage is another controlled breath technique to allow for clearance of secretions. Autogenic drainage is probably the most technical and hardest to learn, but yet one of the most effective. So we'll talk in lab and during the discussion section for this technique that you have to find the right patient to teach autogenic drainage to. Like a young child would not be able to do this technique. It's just too technical. You would never want to teach a really complex secretion clearance technique to somebody who has an acute secretion load. There's many other techniques that can work if somebody has like a pneumonia that they just need to clear secretions, and this point of their life will pass and they won't have lifelong secretions to deal with. But someone with a diagnosis like bronchiectasis or cystic fibrosis, they will be dealing with secretions for the rest of their life. So it might be more appropriate to spend the time to teach a much more complicated technique like autogenic drainage. The technique itself requires the patient who is doing the breath to use both their hearing and their feeling sensation of their secretions to know when to transition between different phases. And basically it utilizes different lung volumes to start in the deepest area of the lung and move secretions up and then up again until ultimately they can leave the lung. So we'll go through this chart in our discussion section, but there are 3 phases or 3 stages that work to unstick the secretions, especially really deep in the lung, collect the secretions as you get to greater lung volumes, and then ultimately evacuate the secretions as you get to these really big full lung volumes that will ultimately become a huff. So you guys will have the opportunity to do these together in the discussion section, and we'll walk through the physiology, especially of this phase 1 and phase 2 at that point. Finally, there's a number of mucus clearing devices. So the first one here is positive expiratory pressure, or a PEP device. We have these in lab for you to be able to see and look at. The PEP device has a mouthpiece, and it's attached to a one-way valve. So it allows expiratory resistance when you're breathing out. By giving you resistance on the exhalation phase, it generates a positive pressure to help keep your airways open. So this is like a supercharged pursed lip breathing. So pursed lip breathing increases the positive pressure. This goes much beyond that with higher pressures that will help keep airways open. So one of the reasons it's hard to clear is because you get that upper airway collapse. This can help keep those airways open. So they do a big inspiration to vital capacity. The more air in, the better. They do a 3-second breath hold for the same mechanism that we talked about in active cycle of breathing, that you want time for air to move between the alveoli distally in the lungs. And then you exhale slowly against the resistance through the device. Slowly here because too much pressure will cause that upper airway collapse. So slow and controlled exhalation to allow just a constant flow past that mucus. You repeat 10 to 20 times, then you finish with a huff to clear the mobilized secretions. So I have a PowerPoint schematic to kind of just re-illustrate how this is a supercharged pursed lip breathing. So here you have kind of the lung drawn as a single alveoli. You can see there's 10 millimeters mercury elastic pressure, but positive 30 coming from the outside muscular system pushing on the outside of the walls, which means all the way up the tree, there's positive 30 millimeters of mercury beyond on the outside of the airways. So when the pressure inside the airways gets less than 30, they will begin to collapse. So by putting the PEP device, and I added our little filter that we use in lab so that we remember that we're being clean, our patient would put this piece directly in their mouth. When you add the PEP device, it adds positive pressure to the airways, and it helps to open that airway back up to allow for the flow to continue to leave. And really, really important is that pause on the inspiratory phase. You will only move mucus if there's air going by it, so you need to allow time for the air to move between the alveoli. Then there are a number of positive expiratory pressure devices that add vibration. The device on the screen that you see here is the Flutter. It's a combination of PEP with high frequency oscillations. There is a metal ball that's in this device that as you breathe out, it shakes and rattles and creates the oscillations. So this device has to be used upward. That's kind of a negative of the Flutter. It's dependent on gravity to like hold the ball in. But it's a really small device, cheap, no bells and whistles, will work anywhere and create this PEP with vibration. So by adding the vibration, you get the benefit of the PEP, the positive expiratory pressure, to add positive pressure to the airway. But then the vibration loosens the mucus and facilitates the mucociliary apparatus. Basically, the mucus elevator gets stimulated by the vibrations. As I mentioned, there's a number of these devices that we'll show you in lab. We have the acapella. This is nice because the acapella doesn't require gravity, so you can do this in dependent positions when trying to clear. The arabica is a nice option. It actually has, so the mouthpiece is on this side, and it actually has an opening here that you can use with a nebulizer treatment. So you can actually do your clearance techniques while receiving some of your meds. So that can be really nice. The arabica, you can set the resistance, how much you want, how much pressure you want during the expiration phase. Basically, you set an amount that causes your expiration to be somewhere between 3 to 4 times longer than it is at rest. So you set the resistance on a device that has a ability to change the resistance. You set it so that when you time their expiration, when they're on the device, that level of resistance elongates the expiration by 3 to 4 times. So for all of these, you inhale to vital capacity, you do your breath hold to allow the gas to move between the alveoli, and then you exhale slowly through the device and allowing the oscillations to occur. We educate patients on not letting their cheeks flutter, and you guys will have a chance to feel this in lab, but if you allow your cheeks to flutter, it absorbs a lot of the vibrations and they don't go down the airways. So you have to hold your cheeks kind of firm to allow the vibrations to kind of go inward. 3 sets of 15 exhalations over 12 to 20 minutes, and you do a Hofer cuff after each series. This picture is showing you the high frequency chest wall oscillation. This is a vest. It's an inflatable vest that uses positive air pressure to create pulses applied to the chest. And the pulses that are applied to the chest create a cough-like shear force within the lungs. So it's a beating on the outside of the chest, but it creates internally cough-like shear forces on the mucus. This is a fantastic device. Almost all of your patients with cystic fibrosis will have a device like this at home. In fact, we'll talk in lab a bit that it can be problematic when this is their primary form of clearance. If they had to have some kind of thoracic or abdominal surgery, they might not be able to use their vest. So somebody might have been independent with their secretion management, but because of a surgery and they can't use their vest anymore, you might actually be teaching them some of the other approaches just as a bridge until they can get back to their vest. The reason this is so popular is that it can be used without assistance. So it doesn't need a caregiver. You can use this in any position. You can go into a gravity-dependent drainage position, and that's fine. It percusses all sides of the chest at once. You can wear this while you're receiving an aerosol bronchodilator treatment. So anything you can do to stack some of these medical interventions can be really helpful, because these become incredibly time consuming for patients. The amount of time they have to spend in their day doing secretion management can become overwhelming. So anytime you can do two things at once, it can be really helpful for the patient. Plus, with the bronchodilation, they can get a better clearance of their secretions as well. Typically, they'd wear their vest for about 30 minutes for a clearance technique. The disadvantage is it is expensive. It's incredibly bulky. You guys will see it in lab. So if you're traveling, it's not an easy thing to bring with you. These little PEP devices, you can throw it in your purse. You have it no matter where you go. This has a big suitcase, kind of a large footprint that comes with it. And again, it's not appropriate if there's any kind of new surgery or surgical incision. So there's times when it's not possible. There is also a cough assist device. This is called the insufflator-exsufflator. The insufflator is blowing air into the respiratory system. The exsufflator forcefully expires the air. It works by slowly inflating the lungs, and then there's an abrupt change that creates a negative pressure to cause the rapid exhalation. There's a brief pause, and the whole cycle begins again. So this device can be used with a mask. That would be a non-invasive use. If it's used with a mask, the patient has to be aware of the timing, because they have to close their glottis in between to allow for that pressure to build up. So they have to kind of learn the timing of the machine. But it can be used invasively, even in unconscious patients, to stimulate the cough. In fact, in Europe, they use a cough assist device more than they do suction. And there's some really good data coming out on the benefits of this device in patients who can't assist in the cough in any way. So for really weak patients, this can be a really helpful device. There's a lot of patients with spinal cord injury that use a cough assist device to try to get better cough and clear their airways. So our patient who had come in and was diagnosed with bronchiectasis went through 6 weeks of pulmonary rehab. Her treatment included upper body ergometer for 10 minutes, treadmill walking at an RPE of 5 for 20 minutes. She did strength training of her upper extremities 3 times a week, and she utilized pursed lip breathing throughout. She received manual therapy, soft tissue mobilization of her cervical musculature, manual techniques to facilitate secretion clearance, and she became independent using a vibratory PEP device and using active cycle of breathing to clear her secretions. At discharge, she demonstrated independence with her home walking program. She's going to keep a log. Her home exercise program for strengthening and flexibility. Her use of the a cappella and active cycle of breathing technique. And she could verbalize the implication of exercise and secretion clearance on her disease process and progression. There's a lot that can be done in a state with irreversible airway dilation, which is going to collect secretions for the rest of this patient's lifetime. So we can give them the tools to manage those secretions so they can stay as healthy as possible and as active as possible. All right, I hope you guys enjoyed the secretion talk. More coming your way in lab. I will see you soon.